So we will be discussing diseases of the aorta. In this format, we will be talking about thoracic aortic aneurysms in this format, acute aortic syndrome. Let me decrease the size of the slide a little bit. And then we will close by some comments on abdominal aortic aneurysms. So the thoracic aortic aneurysms, half of it is in the ascending aorta, a small percentage is in the arch, and about 40% is in the descending aorta. 25% you have concomitant abdominal and thoracic aneurysms, which is a big problem actually. So the commonest etiology of thoracic aortic aneurysm is actually cystic median necrosis. In this condition, there is smooth muscle necrosis and elastic fiber degeneration that results in cystic spaces. This cystic spaces is full of proteoglycans, which is a mucoid substance of the matrix. And as a result of this cystic spaces, there is weakening of the aortic wall, particularly of the ascending aorta, but may involve the entire aorta. Right from the beginning, if you think of an aortic disease in a certain location, then you should consider the whole aorta is pathological, even if it's just a congenital anomaly like coarctation, for example. Coarctation is a diffuse disease of the aorta, so the whole aorta should be imaged in every condition in which you think that there is a pathology localized to a certain area. Cystic median necrosis is usually present as a part of Marfan syndrome, but it can exist in a variety of conditions, including the bicuspid aortic valve and even atherosclerosis. There is an annular aortic ectasia in which the root of the aorta is a term which is applied to the aortic valve, aortic ring, and sinuses of Valsalva up to the sinotubular junction. So this is what's called the root of the aorta. So there is a form of thrust of Marfan syndrome, which is associated with annular aortoectasia, and these forms of Marfan shouldn't be overlooked because of its important connotation, as we will come to. Genetic aortic diseases are very common. 15 to 50% of patients with bicuspid aortic valve, they have an aortopathy. Everybody knows that. But it is important to recognize this because many patients do not realize that they have a bicuspid aortic valve. So if you get a bicuspid aortic valve, you should screen first-degree relatives in a cascade fashion in order to exclude or to diagnose an associated aortopathy. Familial aortic aneurysm can exist without being associated with other congenital anomalies. And again, if you have one or more member of first-degree relatives affected, then you have to screen the first-degree relatives if they are below the age of 70. Another important etiology, which is more common in the descending aorta than the ascending aorta, more common in the abdominal aorta than in the thoracic aorta, is atherosclerosis. It starts with an intimal plaque. The plaque, when it enlarges, it impinges on the media of the aorta, degenerating the elastic fibers and the collagen fibers, and resulting in weakening of the aortic wall. And this is very common in the descending aorta, particularly in the thoracoabdominal area. Uncommon causes include silent aortic dissection. Many people think that aortic dissection can never be silent. It can be silent. It can be associated with minimal pain. Of course, it's usually an agonizing, disturbing pain that has never been experienced as intense before, but sometimes it's just a mild form of pain, and sometimes it's silent. Far less common than silent myocardial infarction, but it exists. Of course, none of us show syphilitic aortitis except in the pathology museum, but one day it was common, no longer, of course. I never saw a case except in examinations. And vasculitis, like Takayasu and giant cell aortitis, and of course, mycotic aneurysms as a result of infection, particularly there is a salmonella prediction for the affection of the aorta. The two common forms of aortitis are those belonging to giant cell aortitis, which is a part of the polymyalgia syndrome. Occurs in 15% of patients with giant cell aortitis with aortic involvement Of course, common in elderly women associated with severe agonizing pain in the pectoral region, sometimes in the pelvic region, associated with stiffness in the morning, high sedimentation rate, high C-reactive protein, and prompt response to corticosteroids. May present with fever and occlusive symptoms in the acute stage and definitely in the chronic stage. And Takayasu aortitis also can occur and starts with fever in the acute stage and the occlusive manifestations in the chronic stage, which is not, of course, restricted to Asian women as described in the early reports of these cases, and may be associated with aortic, pulmonary, and peripheral vascular occlusion. Left subclavian artery must be involved in the large majority of these cases. Sometimes the right subclavian artery, but the left is almost always involved in Takayasu arteritis. Visceral occlusions can occur in these conditions. The clinical manifestations, most of the patients with thoracic aortic aneurysms are asymptomatic. They show themselves at the beginning or for the first time as a ruptured aortic aneurysm. It might affect the aortic valve because of dilatation of the aortic ring and lack of opposition of the aortic leaflets and present with aortic insufficiency. Large aneurysms, of course, can impinge on a variety of structures on the back, producing gnawing pain, on the trachea, producing cough, recurrent laryngeal hoarseness of voice, and can impair esophageal peristalsis, resulting in dysphagia. You have a variety, a whole library of genetic defects that can affect the aorta, but I think the most important of these are these four. Marfan syndrome with its skeletal features. I will come to the criteria for diagnosis of Marfan next. And at the same time, it's the result of the fibrillin gene mutation. Fibrillin has two functions. Number one, it strengthens the elastic fibers, and so it gives it tensile strength for the aorta. But more importantly, it gets attached to the transforming growth factor beta. And if it is mutated, it gets dislinked from transform TGF. And as a result of that, you get strong TGF signaling, and this produces the cystic medianocrosis characteristic of Marfan and other congenital anomalies. Lewis-Dietz syndrome is associated with bifid uvula. I will show you a picture in the next slide, or a cleft palate. It's associated with arterial tortuosity, widely spaced eye. It's a very dangerous condition because it can produce rupture of the large vessels, even if they are of normal dimensions. If you have a Lewis-Dietz, then it's important to image the vascular system from the head to the pelvis. Ehlers-Danlos, it is Danlos, not Danius, as it's written here. Ehlers-Danlos syndrome type 4 is a vascular disease, and the mutation is in COL3A1. It's associated with thin, transparent skin, gastric rupture, uterine rupture, and rupture of medium and large arteries. And Turner syndrome, everyone recognizes that Turner is associated with bicuspid aortic valve as well as with coarctation of the aorta, but you have to remember that it's also associated with aortic dissection and aortic aneurysm. Of course, it's 45XO karyotype. So this is a whole library of conditions, and is expanding. 25% of patients with ascending thoracic aortic aneurysm, they have a genetic basis. The commonest by far is the ACTA2, or in which there is mutation of the alpha actine. It's important to recognize this by applying a library of genetic studies, and this is it's going to facilitate recognizing siblings and offsprings, which are the first-degree relatives. This is a picture of Lewis-Dietz, the bifid uvula. Sometimes it's a broad uvula, and sometimes it's a trilobed uvula. Red flags for the diagnosis of thoracic aortic aneurysm includes a family history of aortic dissection, bicuspid aortic valve. Remember that cerebral aneurysms are commonly associated with the aortic aneurysms. So cerebral aneurysm and popliteal aneurysms, any evidence of that, you should image the whole aorta to exclude the associated and more serious aortic aneurysm. History and physical examination looking for Marfan features, bifid uvula of the Lewis-Dietz, velvety skin of Ehlers-Danlos, and of course hypertelorism and osteoarthritis. Premature osteoarthritis, severe form of osteoarthritis occurring in young age, particularly young females, may be associated with aortic aneurysm. It's a genetic disorder that should not be overlooked. Now, what is the diagnostic modality that is preferred? By far, the most important diagnostic modality is CT with three-dimensional reconstruction. It's very important that you take the dimension of the aorta perpendicular to the axial flow of blood. And it is very important at the same time that if you repeat the examination of the aorta, you repeat it by the same modality of examination, and preferably in the same institution, and preferably by the same person, because of differences in the method by which aortic diameter is being evaluated. There is a contraindication to CT. We go to MRI. And there is now attempt at creating hybrid imaging using CT for calcification and the MRI for tissue characterization in order to get an optimum and holistic view of the aorta and its different segments. At the same time, if the disease has been proved to be restricted to the aortic root, particularly the very start of the aortic root, then probably an echocardiogram is sufficient. So this is the different methods by which the aorta is being imaged. The sensitivity of CT is done in a gated way, ECG gated, in order to remove the movement artifact, because remember that the aorta is a moving structure. So the movement artifact may blur the CT image, but if you get the gating for the ECG gating for the CT image, then it nullifies the movement artifact, and its sensitivity under these circumstances is 100%. Specificity is 98 for MRI, CT, and at the same time, you have to be cognizant that these are very important to be repeated in the same way, in the same institution, preferably by the same person. Multimodality imaging is definitely superior to a single modality imaging in evaluating the aortic diseases. Now, what is the natural history of thoracic aortic aneurysm? They don't stay static. They grow. They grow and dissect. They grow and they press on surrounding structures, producing symptoms, and they may grow and rupture. So it's very important to realize that if you have an aortic aneurysm, then this will result in problems eventually. And we apply the word aneurysm to localize the dilatation that's 1.5 times as large as a predicted segment of the aortic dimension. The ascending aorta is usually 5 centimeters long and is 3 centimeters wide. If it exceeds the 3 centimeters, because the average is 2 centimeters, 1.5 is 3. If it exceeds 3, it's considered as aneurysm. The descending thoracic aorta is 20 centimeters long and is 2.5 centimeters wide, and the abdominal aorta is 15 centimeters long and 2 centimeters wide. In excess of that, if it's a localized dilatation, then it's by definition an aortic aneurysm. Now, the thoracic aortic aneurysm is really a very malignant disease. Within 2 years, you would get a mortality rate of about 50%. Within 5 years, the mortality rate is about 80%. So as a result of that, it should be timely diagnosed and properly treated. Now, what is the cutoff point? This is very well illustrated in all the studies. Probably none of you saw these studies, but if you see here, if you are talking about the ascending aorta, there is an inflection point here at 6 centimeters, slightly shy of 6 centimeters. So beyond that, you get marked increase in the incidence of aortic rupture. So as a result of that, we operate just before the inflection point. So we choose 5.5 in the large majority of cases of ascending aortic aneurysm. In the descending thoracic aneurysms, the inflection point is shy of 7. So we operate before that. We used to operate at 6, but now because of the advances in different modalities of treatment, we operate again at 5.5, and we will detail that. Having said that, let's take a case. If a 45-year-old woman presents to you for a second opinion, she has been diagnosed as Marfan and carries the diagnosis of ascending aortic aneurysm. Her cardiologists have been ordering an annual MRI studies for her ascending aorta and an echocardiogram for a leaking aortic valve. In the last study, he recommended surgery. She is refusing surgery at that time. Physical examination is consistent with Marfan. Blood pressure slightly elevated. Pulse is 56. Lungs is clear. The estimated right atrial pressure is sub 7 centimeters of water. Carotids are brisk. Our cardiac examination reveals an accentuated A2 and systolic and diastolic murmurs of aortic regurg. Her last aortic MRI shows sinotubular dilatation with a maximum dimension diameter of 4.4. Her last echocardiogram shows 3+ aortic regurgitation with normal chamber size and function. So we are dealing with an asymptomatic lady, and these are the dimensions. Now, what is the treatment that you would suggest as a second opinion? Replace her aorta and replace her aortic valve to prevent dissection and heart failure, or initiate treatment with beta blocker and reduce aortic dilatation, or replace her aorta and leave her aortic valve so you see if the aortic valve is going to improve, or give her ARBs, or replace the aortic valve and see if the aorta improves over time. Now, as you see, this is a lady, and she is totally asymptomatic, and neither the aortic diameter nor the indication for aortic valve replacement has yet reached. The aortic diameter, as I indicated, for an ascending aortic aneurysm is 5.5. This is 4.4. At the same time, there is no ventricular dysfunction. Patient is asymptomatic, so there is no indication either to replace the aortic valve or replace the aortic root. So the correct answer is D, initiate treatment with ARBs to reduce the blood pressure. Some people might think that beta blocker is the answer, but remember the patient is having a pulse rate of 56, and at the same time we have to be cautious in the use of beta blockers in patients with aortic regurg, prolongs diastole and aggravates the aortic leakage. Now, what are the criteria for diagnosis of Marfan syndrome? These are called the revised Ghent criteria. Ghent is a city in Belgium. And as you see here are the big names in aortic disease, Lewis Dietz and Bart Lewis and Harry Dietz and Biverman. So these are important people. And the diagnosis of Marfan is depending whether we have a family history of Marfan syndrome or there is no family history of Marfan syndrome. So if there is no family history of Marfan syndrome, then aortic root dilatation and the ectopia lentis, that's Marfan syndrome. Or aortic root dilatation plus fibrillin mutation, that's Marfan syndrome, or aortic root dilatation, the systemic features, which I will show you in the next slide, 7 points or more, Marfan syndrome, or ectopia lentis and the fibrillin mutation, that's Marfan syndrome. So this is in the absence of family history. If you have a positive family history, then it is sufficient for you to get either ectopia lentis or systemic features more than 7 points or aortic dilatation. Any of these is sufficient to diagnose Marfan syndrome. Now, if you look to, these are the systemic features. You are not supposed to remember them, but just for the sake of completion and your identification. The wrist sign, that's wrapping your thumb and your little finger, and you get an overlap by one segment. The wrist or thumb sign, that's folding your thumb and getting one segment of the thumb outside the fist. Pectus carinatum, pectus excavatum, hind foot deformity. By this we mean that the heel is rotated outward. So you can read the rest of here. These are the points, the point system that features the scoring system for Marfan syndrome. If you get 7 points or more, in addition to the one of the things which we just mentioned, then it's enough to diagnose Marfan syndrome in the absence of family history. Or if you get them alone in the presence of family history, then this is sufficient to diagnose Marfan syndrome. This is ectopia lentis. It's a very important manifestation of Marfan syndrome, but it can be the result of other conditions like hemocystinuria, Weil-Manchancy syndrome. This is a broad head, stiff joints, as well as ectopia lentis, and as well as Ehlers-Danlos. So these are the 4 common conditions that produce ectopia lentis. Obviously, you can detect it clinically by the presence of tremulous iris. You shake the patient of the head. You allow the patient to shake his head, you get tremulous iris, or by slit lamp examination if it is just a subtle dislocation of the lens. Now, if you look into the natural history of Marfan, you will find it much more serious than the natural history of non-Marfan individuals. So as you see here, this is in the yellow line is the natural history of Marfan syndrome. These patients get a higher mortality rate, higher than the mortality rate of the non-Marfan patients. And as a result of that, we elected to repair the aorta at a lower cut-off point than 5.5. So we elected Marfan 5 centimeter, not 5.5. Now there is also attempts at indexing the diameter of the aorta to the body size or to the body height, but there is no evidence that using this method adds more improvement to the usual diameter dimension that we are using. So don't disturb yourself by it. Now these are the diameter thresholds for elective repair. In patients with degenerative condition, idiopathic conditions, 5.5. In patients with Marfan syndrome, 5. And if the patient is having Marfan syndrome and at the same time is having rapidly growing aortic aneurysm of 0.5 centimeter per year or more, or is having a family history of dissection, then we can go more aggressively, and the cutoff point turns out to be 4.5. In patients with familial thoracic aortic disease, 4. Bicuspid aortic valve, this is important. Bicuspid aortic valve, 5.5, because it has cystic medial necrosis like Marfan syndrome, but it is less serious, less serious than Marfan syndrome, so it's 5.5. But if you have a family history of dissection, then you can go to less than 5.5, 50. If the patient is having bicuspid aortic valve and you are going to operate on the bicuspid aortic valve, then you can operate on the aorta as well at 4.5. If the degree of enlargement is more than 0.5 centimeter per year, you can still operate at 4.5. So the classic is 5.5 unless you have associated condition which increases the risk of the aortic root rupture. And under these circumstances, you have to operate on a lower threshold. Lewis deeds, as I indicated, is due to the mutation of the transforming growth factor B receptor 1 and 2 as associated with arterial tortuosity. It's a very significant, highly lethal condition. These patients, they have Marfanoid features, and we operate more aggressively than the other cut-off points, so it's at the level of 4. Some say that Lewis deeds, once you diagnose it, you operate. Ehlers-Danlos, again, 4, more aggressive than in Marfan syndrome. What about the surgical approach to patients with aortic with descending thoracic aortic aneurysm? Of course, the most feared complication is the post-operative paraplegia due to interruption of the arterial supply of the spinal cord. Particularly, there is a large artery which goes from the aorta to the central part of the spinal cord, called the artery of Adam Kewix. It emanates from the aorta at the level of lumbar 1 and gets interrupted easily during operations on the abdominal or thoraco-abdominal aorta. But there are certain techniques that decrease the post-operative paraplegia from previous figures of 5 to 6% down to 3%. This includes regional hypothermia of the spinal cord with epidural cooling, or reimplantation of the patent intercostal arteries, or spinal fluid drainage. Of course, in addition to this dreaded complication, we have the other usual complications of post-operative vascular surgery, including heart failure, myocardial infarction, pneumonia, etc., etc. Now, the descending thoracic aortic aneurysm are being progressively treated now with EVAR, with TVAR, endovascular stent graft repair, as an alternative to surgery. It's far less invasive than surgery, with fewer immediate post-operative complications. But as you proceed, as time passes by, there are a lot of complications. At least 1/3 of these patients got complications. So as a result of that, after 3 years, the outcome is the same. So this diagram shows here the Kaplan-Meier curve. The Kaplan-Meier curve shows that the TVAR at the top here, early on, the TVAR is having less complication, less mortality than open repair. But after 3 to 4 years, the two curves converge together, and the mortality and morbidity is the same. And we'll come to that again. Medical therapy for thoracic aortic aneurysm is essentially the beta blocker to diminish the rate of rise of left ventricular pressure. And we have to use it in the maximum tolerated dose to keep the heart rate between 50 and 60. And remember, the most aggressive blood pressure control in medicine is in aortic aneurysms and aortic dissection. So the systolic blood pressure should be brought down to 120 or less. By beta blockers essentially, but you probably need the addition of ARBs, inhibitor, calcium channel blockers, and diuretics, and the blood pressure should be monitored. These patients should never run out of medicine. They should have the medicine regularly taken, and the blood pressure should be very aggressively treated under these circumstances. And to make sure that there is nothing going wrong, serial imaging is important. In the serial imaging, we start first close by imaging at 6 months and then annually. And as I told you, it's better to use the 3D reconstruction of the CT. You cannot repeat the CT several times. We replace it by MRI. If we get a hybrid machine, then this is going to be okay. If the abdominal, you have to image the whole aorta, at least at the beginning, but better to be imaged every time you screen for the thoracic aortic aneurysm. You image the aorta down to the bifurcation and probably the common iliacs. So the guideline indicates that medical treatments are class 1 beta blockers, bringing the blood pressure as low as you can, better to be below 120. Smoking cessation. Smoking is #1 risk factors in the occurrence of aortic aneurysms and aortic dissection, so it's completely banned. Class 2A is losartan, which is an antagonist of the transforming growth factor beta, which has an increased signaling results in dissection. How frequent you follow up these patients by imaging for acute aortic dissection in the first year 3 times, and then yearly. For the next 4 items, chronic dissection, aortic root repair, aortic valve replacement, and aortic ascending aorta replacement, and the aortic arch, yearly. Thoracic aortic dissection, like acute dissection, 3 times in the first year and then yearly. And for intramural hematoma and penetrating aortic ulcer, before discharge and frequently in the first year and then yearly. So this is important for the follow-up of these conditions. So it's important to realize that if you have an aortic aneurysm which is newly diagnosed and is in this range at the bottom of the slide between 3.5 and 4.4, you need annual revision by imaging. But if it jumps to 4.5 to 5.5, you need imaging every 6 months. Of course, if you get symptoms, you operate immediately. Don't wait for these dimensions to occur. So these dimensions are for the asymptomatic individuals. The occurrence of any symptoms related to the aorta, pain, hoarseness of voice, tracheal compression, any of these things is an immediate indication for intervention, whether this intervention is surgical or procedural. And there is nothing called a cooling down interval in the field of aortic aneurysms. Now we move from thoracic aortic aneurysms to another important subject, which is acute aortic syndrome. This is a term which applies to these 5 conditions: aortic dissection, classic intramural hematoma, penetrating atherosclerotic ulcer, rapidly expanding aortic aneurysm, and the traumatic aortic dissection. So this is the classification which is known to every one of you. Probably most of us like the Stanford classification. Stanford classification type A is involvement of the ascending aorta, and type B is anything else. But of course, this is different from the Baker's classification. The Baker classification type A is ascending aorta and going by definition distal to the innominate. Usually it involves the descending aorta down to the bifurcation. And type 2 is ascending aorta only stopping short of the innominate artery. And type 3 is distal to the ligamentum arteriosum or left subclavian and going down to the bifurcation. There is a European classification. It's important to realize that only type 3 in the European classification. Type 3 here is something new in which there is a little bulge in the wall of the aorta. It can be in the ascending aorta or in the descending aorta. This little bulge is not an intramural hematoma. It's a small tear which results in dissection localized in this way. Actually, we don't know what is the optimum line of treatment for type 3 of the European classification, but there is an evidence that when it's present in the ascending aorta, it's dangerous and requires surgical intervention. And when it's present in the descending aorta, it's usually more benign and can be treated medically. The American classification in the IRAD, which is International Registry of Aortic Dissection, hyperacute in the first day, acute in the first week, subacute in the first month, and chronic after the first month. Again, the European classification puts chronic at 6 weeks and identifies longer time intervals than those of the American classification, but the difference is not marked. Now, the different risk factors for aortic dissection includes advanced age, male gender, history of hypertension, non-aortic aneurysm, of course, Marfan and bicuspid aortic valve, and a postpartum period. Young individuals in training for cardiac catheterization usually remember how frequently they dissected the aorta when they went from the groin. So this is iatrogenic dissection. And post-cardiac surgery, at the site of clamp application, you get weakening of the aortic wall. Particularly many of these patients, they originally have bicuspid aortic valve that has not been diagnosed. So already the aortic wall is weakened. You apply the cross clamp, you further weaken it, and it can be the nidus for dissection. It's rare. The dissection is rare, but half of them, they die at home and never show up. It's a life-threatening condition with early mortality for the first 24 hours of 1% per hour. And survival can be improved by surgery, of course. It can present in a classic way or can be present, as I indicated, in a non-specific way, and even without risk factors. So you have to be on the lookout. I will show you how can we diagnose it. The classic features, of course, is acute chest pain that starts anteriorly in ascending aortic dissection, goes to the interscapular region, moves to the back, and then the lower back, and then to the legs in a march, which indicates the passage of dissection in type 1. The pain is usually abrupt in onset, it's usually severe, it's the worst that has been perceived by the patient. It decreases after that, in contrast to the pain of myocardial infarction, which has a crescendo configuration. The pain is described as tearing or ripping or stabbing. It migrates in the way I just, and the patient cannot lie back, so he's restless and cannot get comfortable in any way. If you look to this slide, you will find that the large majority of patients, the pain is abrupt, and usually it's anterior in patients who are having a type A dissection, proximal dissection, and usually it's posterior, but there is much overlap. About 9.5 or 10% of the patients, they get syncope. The syncope is usually the result of the dissection involving the cervical vessels, or it can be the result of cardiac tamponade, the dissection going down to the root of the aorta, slipping into the pericardium, producing cardiac tamponade. Of course, this tamponade is one of the tamponades that should not have a paracentesis. If you do paracentesis for patients with aortic dissection, you increase the amount of leakage into the pericardium unless the patient is in the extremis. Same applies to cardiac rupture. You shouldn't pericardiocentesis the patient with cardiac rupture because the tamponade is splinting the rupture. But if the patient is in the extremis, then you can tap the pericardium while the operating room is being prepared. How we diagnose aortic dissection? This is the algorithm proposed by the American College of Cardiology. You have 3 groups of conditions here: high-risk conditions, high-risk pain, high-risk features. The high-risk conditions like Marfan syndrome, family history of aortic disease, non-aortic valve disease, recent aortic manipulation, or non-thoracic aortic disease. And the high-risk pain features essentially abrupt and severe ripping pain, and the high-risk exam features pulses, deficit, phenologic manifestations, murmur of aortic insufficiency. Anyone on any group takes 1 score. So if you have any one of these 1, and this 1, and this 1, if you have the 3, then you got the diagnosis. The patient is 100% having an aortic dissection. If you get 2 of these, then you need further imaging. If you get none or 0, the possibility of aortic dissection is just 4%. 2% out of these 4, you have widened mediastinum. So although the slides looks complex, it's very easy. You can diagnose 98% by applying of cases of dissection by applying this algorithm, and the rest of the 100%, 2% is very difficult for anyone to diagnose. Now, this is the European algorithm. It depends on the same manifestations and same criteria that I indicated just now, but it takes in consideration whether the patient is stable or unstable, as well as the use of D-dimer, which I will come to it. This is the value of the D-dimer, the line in yellow. The D-dimer is the only biomarker which is approved for the diagnosis of aortic dissection. Usually, aortic dissection is having high figures for the D-dimer over 500. So remember that if you have chest pain with D-dimer, the diagnosis is not always pulmonary embolism. It can be an aortic dissection. The calponin, which is the smooth muscle troponin, it can also be a reliable index, but it's not approved so far. And the other, like CK and CKMB and the myosin, are not very reliable in the diagnosis. Of course, the detection of a biomarker for aortic dissection is going to be of extreme help in these conditions. Intramural hematoma. This is a hematoma in the aortic wall. I remember when we used to diagnose patients with aortic dissection by doing cardiac catheterization, we did that for several years. We were missing a completely intramural hematoma. It doesn't show up with cardiac catheterization and the invasive aortography. So had patients who have having classic picture of the dissection, we go in, we injected the aortic root, we find nothing. And then we get a problem, the patient died, we'll get an extensive dissection, and so on. This entity was not known at that time. It was born with the birth of CT and intravascular ultrasound and sometimes thoracic ultrasound. So it constitutes about 15% of patients presenting with acute aortic syndrome. It's the result of either rupture of the vasa vasorum or a small tear, which results in leakage of the blood in the wall of the aorta, and then it closed. So as a result of that, you get trapping of the hemorrhage into the aortic wall. Natural history, it can absorb, it can extend and produce a pseudoaneurysm, or it can extend and result in aortic rupture, or it can extend and produce classic dissection. So you have 4 outlets for intravascular hematoma. But this is an entity which is very important. And as you see here on the left side, you have a classic dissection here. and on the right side you have an intramural hematoma. This intramural hematoma has a crescent moon appearance. Sometimes it's circular all around, but usually just a crescent-shaped structure here appearing in this way. It has the same connotation, prognosis, natural history like dissection, same presentations, and the treatment depends on whether it's in the ascending aorta, it will be surgical like classic dissection, or in the descending aorta, where we can treat it medically or by TVAR. Traumatic aortic dissection, usually these people, they die in the scene, they get a catastrophic injury in the part joining the mobile aorta, which is distal to the ligamentum arteriosum, and the fixed aorta, which is the arch. And if you get decelerating trauma, you get vigorous movement at this area, leakage of the blood. Usually these patients die in the scene. But there is now attempts to therapeutically help these patients by endovascular repair, but this is usually very energetic endeavor. Now this shows the importance or the relative importance of surgical various medical treatments in various parts of various types of aortic dissection. So in proximal dissection, as you see, these areas correspond to acute or hyperacute, acute, subacute, and chronic dissection. And as I indicated, hyperacute is in the first day, acute first week, subacute in the first week, and then chronic after the first month. So as you see here in type A dissection, proximal dissection, surgical treatment is by far important in all the stages of the aortic dissection. By far is more important, and the survival is by far better with surgical intervention than with medical intervention. On the contrary, as everybody knows, in type B, you will have, which is a lower figure here, you have strong evidence that medical or endovascular therapy is much more important in getting lower figures of mortality, higher figures of survival than surgical treatment. So whether you are having an acute, hyperacute, acute, subacute, or chronic aortic dissection, the difference is existing and may be exaggerated even in the chronic phase. So therapy for acute aortic syndromes in general, proximal aortic dissection, upfront medical therapy, which includes beta blocker to diminish the TPDT and shear stress, and intravascular vasodilator after you make sure that you have beta blocked these patients. And unless there is contraindication like extreme comorbidity or very advanced age, then urgent surgery is always indicated. And preoperative evaluation should not include cardiac catheterization. We used to catheterize this patient. We spend a lot of time. What you do is just to get extension of the aortic dissection, and you create another dissection in the aortic root. And usually it's very difficult to get into the coronaries. If you get into the only indication, the only condition in which cardiac catheterization is now being implemented in aortic dissection is when you miss the diagnosis and you diagnose the patient as coronary artery disease, and you find yourself in the coronaries, and under these circumstances, you might elect to shoot the coronary artery. That's easy. Otherwise, don't waste your time. Don't waste the time of the patient, because as I said, mortality rate is very high as hours pass by. Pericardiocentesis is contraindicated unless the patient is severely compromised. Under these circumstances, you decompress the patient by as little blood from the pericardial sac as possible. But if the patient is stable, don't decompress the patient by pericardiocentesis. Move him directly to the cardiac catheterization leg and do the paracentesis there immediately before the patient goes on bypass. Usually the bypass here is taken right axillary artery and the femoral vein. I hope this slide can be seen. This is a summary of what we just said. If you suspect If you suspect an aortic aneurysm, then it's either type A or type B. If it's type A, it's emergency surgery. If it's type B, you look whether it's uncomplicated, so it's for medical treatment. The role of endovascular therapy is still to be worked out. If there is complication like malperfusion syndrome, rapid expansion, refractory pain, inability to control the blood pressure, then you move the patient to surgery or endovascular therapy. Simple, easy, straightforward knowledge, shouldn't be confused with anything else. What about distal aortic syndromes? As we said, upfront medical therapy should include beta blocker, intravenous vasodilators once the patient is sufficiently beta blocker. And here, barring the urgent indication for operating room, which is the conditions that I just mentioned, expansion, resistant pain, other complications in the form of ischemia of end organs, which is the hyperperfusion syndromes. Apart from that, it's for medical treatment. The indication for surgery are subtle, include rupture, impending rupture, mesenteric ischemia, uncontrollable pain, expansion of the aortic size. Endovascular therapy in relation to medical therapy is still unclear. But of course, the endovascular therapy is gaining a large momentum and is replacing all the attempts. What about the patients who are presenting in the chronic stage? As we said, in the acute stage, type 1, all patients go to surgery. Type 2, they go to surgery, they have complications of rupture, extension, expansion, malperfusion syndrome, or if he's Marfan, and this is doubted. If the patient gets a chronic dissection, that's after 1 month by the American classification, 2 to 3 months by the European classification, then it's treated as an aneurysm, عادي. So if the patient maximum diameter, aortic maximum diameter more than 5.5, if Marfan more aggressive, if there is increase in dimensions 1 centimeter or more per year, if there is significant aortic regurg, and if there is some symptoms suggestive of expansion or compression on surrounding structures. This is type A, chronic, go to surgery. Type B, same like any chronic aneurysm for type B, maximum dimension 6 or more, or increasing rapidly 1 centimeter per year, or symptoms of expansion or compression. So these are the indications for surgical intervention in the acute, proximal, and distal, and in the chronic status, proximal and distal. What after that? After that, control of the blood pressure as aggressive as you can. Maintain always a systolic blood pressure at 120 or below. Serial imaging 3 times in first year and then every 1 or 2 years, and educate the patient. This is very important. If the patient he cannot participate in competitive or body contact sports, and he shouldn't run out of medicine. If he runs out of medicine, then the blood pressure will rise and will result in aortic rupture. Now, there are a group of slides here which I have to jump for the sake of time, and then I will go to the abdominal aortic aneurysm. This actually includes certain things which we just mentioned. So abdominal aortic aneurysm, again, it's a male disease like the thoracic aortic aneurysm. The ratio is probably higher than what's written here. It's about 9 to 1. If the patient is left without treatment, mortality from rupture is 80 to 90%. But if you treat him by elective surgery or endovascular, then it drops from 80 to 90 down to 3 to 4%. So this means that it's a crime to miss the diagnosis of abdominal aortic aneurysm because of the huge difference between treatment and lack of treatment. Risk factors for abdominal aortic aneurysm is number 1, smoking, number 2, smoking, number 3, smoking. And then number 4, male gender, as you get older, family history, and of course, hypertension, atherosclerosis, and the hyperlipidemia. Now, if you look to the different studies, the risk of aortic, I hope the arrow can be seen. The risk of having the aneurysm, this is the odds ratio. Anything below 1 is decreased the risk. Anything above 1 is increased the risk. So if you look to the female sex, you will find that females are less likely to get abdominal aortic aneurysm. But if they get an aortic aneurysm, they are more prone to rupture. So this is 3 here. The hazard ratio is 3. It's above 1. So as you see, if you get a female, then the female is more prone to rupture. But the possibility of getting, the chance of getting a female affected is much rarer than having a male affected. Again, diabetes here is something unique about diabetes. The risk of abdominal aortic aneurysm is less in diabetic patients, probably because of the fibrosis which occurs in these conditions and prevented the aortic expansion. Again, COPD, particularly in patients on steroids, they are at higher risk of rupture. So these are the factors which enhance the occurrence of AAA or aortic abdominal aortic aneurysm. And always remember that the cutoff point of female in females is less than male, because if you get it in a female, which is a rare occurrence, the possibility of rupture is much higher. So if we operate on 5.5 abdominal aortic aneurysm in males, we operate on 5 in females. And this is exaggerated here in this study, which shows the incidence of rupture is much more in females than in males. And obviously, as you get larger aorta, you get more incidence of rupture. So if you are below 4 centimeter diameter, then it's almost like control. So you shouldn't be worried about that. But I will detail enlarge on that soon now. Now, the factors which increase, of course, the risk of rupture is increase the diameter, particularly if you go up in this range between 5 and 6, if you have more expansion, again, smoking, family history, hypertension. Remember that fusiform aneurysms are less likely to rupture than saccular or eccentric aneurysms. So always you should be worried about females and worried about saccular and eccentric aneurysms, and obviously the size of the aneurysm itself. This shows the effect of smoking. As you see here, starting from the age of 50 up to the age of 80, smoking results in 2 to 5 times higher risk of aortic aneurysmal rupture, abdominal aortic aneurysmal rupture than in non-smokers. So you have to be very firm with the patients to stop smoking and never return to that. Should we screen? The answer is yes, and this is a study of 6,000 men aged 65 or more, randomized between screening and no screening. And as you see here, people who have been screened for AAA, they have a less mortality than patients who are not have not been screened. So based on this large study, the recommendations of both the European and the American guidelines was based essentially on this study, as well as on this meta-analysis. The Cox diagram shows you that the risk in these old studies is much less with the screening than without screening. So the recommendations, the guideline recommendations, which are based on this meta-analysis and the previous study, is that this is important. One-time ultrasound screening for men aged 65 to 75 who have ever smoked, because the prevalence of rupture aortic aneurysm, abdominal aortic aneurysm is high here, 6 to 7%. The second recommendation is selectively offered screening for men aged 65 to 75 who have never smoked. The prevalence is just 2%, but again, it's a recommendation. Of course, if these patients are having a positive family history of rupture, they should be screened. Insufficient evidence for women aged 65 to 75 who have ever smoked. The prevalence is much low, but there is insufficient evidence to recommend the screening. But the guidelines recommend against the screening for women who have never smoked between the age of 65 or 75, although it doesn't indicate here, because the prevalence here is just 0.03 to 0.6%. So this is the recommendations, and it's very important to remember them. They are the subject of several questions. This is an example of triple E. What about smaller aneurysms? This is another British study, very important, 1,100 patients randomized, having the aortic dimension, aortic diameter, abdominal aortic diameter between 4 and 5.5 or 5.4. They have been followed for 8 years, and as you see, the two curves are superimposed. So there is no risk. There is no risk here if you have patients with aortic diameter between 4 and 5.5 or 5.4, you can wait. This study gives you comfort that there is no risk of waiting on these patients, and there is no rush to subject these patients to any form of intervention. This again emphasizes the fact that the risk here is in this range between 5 and 6. As you see here, we are jumping from 3% to almost a 10% mortality rate or the risk of rupture. So as a result of that, we operate in this area 5.5. Now, what are the operative mortality risks in these patients? Many of patients are good risk. They are below the age of 70. They are physically active. There is no significant comorbidity. And they are having a reasonable anatomy for the surgeon, then the risk is usually very low, with operative mortality varying between 1 and 3%. Remember, if it's left to rupture, the mortality is going to jump to 80 to 90%. On the other hand, if the patient is above the age of 50, of 80, is inactive, has significant coronary artery disease, has COPD, serum creatinine is elevated, liver function is impaired, then the operative mortality is going to jump somewhere between 3 to 5%. And for every comorbidity, for every single comorbidity, the operative mortality is going to increase by 3 to 5%. So these are some people, they are old, have a lot of comorbidities. So we tell them usually operate at 5.5, but for you, I think we have to wait because the risk is high. So this is the factors that enhance the possibility of having a mortal event with aneurysmal repair. Obviously, is serum creatinine high, above 1.8, heart failure, ECG evidence of ischemia, pulmonary dysfunction, old age, and also female sex. Eventually, these conditions are going to be replaced totally, and now they are being replaced by stent grafting, by putting a stent through the femoral artery. Obviously, you have to have a landing zone here below the renal arteries. If the landing zone is above the renal arteries, renal function is going to deteriorate. And usually there is another segment which goes into the other common iliac. And the main problem with this condition is that 1/3 of these patients are going to get complications. So as a result of that, long-term outcome is equal between grafting and operative intervention. But the immediate outcome is in favor of grafting. So if you just explain this to the patient, many of the patients will say, okay, I prefer to get something which I can be discharged from the hospital after a couple of days. And then we wait if the complications come, then we can face it at that time. Might not come. The main problem with the EVAR or endovascular aortic repair is endoleak. The endoleak, there are 4 types. Type 1 is rare, type 2 is very common. Type 1 is leak at the margin of the stented cuff. As the grafts improve, this leak is decreasing markedly. Type 2 is the commonest type, which is retrograde blood flow through the branch vessels like the lumbar vessels that have been excluded from the aortic lumen. Type 3 is written wrong here. Type 3 is actually leakage of the blood between the different segments of the graft. Remember, there is a limb from the graft coming from the left iliac in the picture that I just showed you. So if you get a leakage between the main graft and this limb, this is type 3 limb. It needs an immediate intervention. And type 4 is usually resolved by itself. It's a diffuse leakage through the porous graft material. So it's this kind of complication which impairs the. This shows the different types of endoleaks. This is type 3, usually dominates the complications even at the different times, 1 month, 12 months, and beyond the 12 months. So endoleaks is a big problem here. And this slide emphasizes the lower rate of mortality rate and mortality and complication, hospitalization and mortality between open repair and endovascular repair. Always in the immediate post-operative period or post-intervention period, the operative mortality and the complication is much less with the EVAR than with the open repair. But as I indicated before, on the long term, this is a follow-up for 4 years and eventually more than that. On the long run, the two curves converge with each other. So early on, there is less mortality and less complications with the EVAR, but eventually, because essentially of the endoleak, but other complications as well, will result in equal rate of survival and equal rate of mortality. And this curve shows that the all-cause mortality as well as graft-related mortality or operative mortality, they are the same at 4 years for the comparison between endovascular grafting and open repair. So as you see here, long term, because of the complications that occur in almost 1/3 of patients with endovascular grafts, the outcome is almost similar after several years. And this shows that open repair versus endovascular repair, these are the complication rate. These are the complications rate, and this is the survival free of intervention. Always with endovascular repair, you get complications as time passes by. And despite that, everywhere people are preferring to use endovascular repair. This is the figures from the United States, and it shows in blue here the increasing the utilization of endovascular repair compared with open repair. And I think this applies also to Egypt here. We are seeing our colleagues working in vascular surgery, changing their career into interventionists to put this endovascular repair. So this shows that the endovascular repair is gaining a momentum. Now we are putting the graft in the descending aorta, but eventually within few years, we will be having a graft for the arch of the aorta and for the ascending aorta, definitely. Within 5 years from now, the expectation is that endovascular grafting will be applied for the whole aorta eventually. So to summarize the situation, abdominal aortic aneurysm is usually asymptomatic until it ruptures, and the ensuing mortality will be very high under these circumstances. Symptomatic patients, urgent repair, no cooling off period. The task force recommendation for surveillance and counseling is for men aged 65 to 75 with a history of smoking should have at least one examination by ultrasound of the abdominal aorta, like 5.5 for men, but less than. Endovascular repair has 8 to 10 years. It's equal to the mortality associated with open repair. Patients who are having endovascular repair, they suffer from complications in 1/3 of the patients. The decision regarding the prophylaxis, whether you pursue prophylactic, that's treating asymptomatic individuals, and which kind of repair, of course, depends on various factors like the anatomy, whether you have a landing zone for the endovascular prosthesis or not, the operative risk, and the patient preference. So I stop at this stage. Thank you for watching this 81 slide, and I hope to get some questions to answer them. محمد باشا.
يا دكتور محمد مع حضرتك.
خلاص أنا خلصت، قول لي بقى الأسئلة.
تمام.
أنتوا شفتوا 80 سلايد، ما رضيتش اخد لكم في الاول.
مساء الخير دكتور محمد، كل سنه وحضرتك طيبين.
دكتور محمد حضرتك سامعنا؟
سامعك.
تقريبا دكتورة وفاء الإنترنت قطع عندها.
ليه؟
هي خرجت تقريبا، مش موجودة.
ممكن تكون كده.
لا مساء الخير يا بيه، انا موجوده اهو.
موجودة اهي.
انا بس كنت بدور على سؤال وبعدين لقيت ان الكلام كله واضح. هو ما فيش سيشن على الارترايتس؟
في سيشن رايتس.
اوكي تمام.
المرة الجاية بريفرال فاسكولار ديزيز برضه سلايدز كتيرة، لكن هنخلصها بسرعة إن شاء الله.
ان شاء الله، كتر خيرك.
اوكي، هو سؤال واحد اللي جه بيسأل عن الميكانيزم اوف سينكوبي ان اورتيك دايسكشن.
الميكانيزم اوف سينكوبي اوف اورتيك دايسكشن حاجة من اثنين، يا اما دايسكشن اكستندنج انتو ذا روت اوف ذا cerebral vessels، يا اما حصل كاردياك تامبونات. يعني يا اما going forward to involve the root of the blood vessels of the arch, or it's going backward and rupturing in the pericardium causing cardiac tamponade as a result of that syncope. طبعا anything can happen including arrhythmia, hypertension بسبب vasovagal بسبب البين والحاجات زي كده. لكن this when the patient is having syncope or fainting, these are the two big things that should jump in your mind and try to figure out. If you have tamponade, don't tap the tamponade. This is one of two situations in which tamponade shouldn't be paracentised. And the other one is cardiac rupture.
اوكي، السؤال الثاني بيسأل is losartan superior to other ARBs in treatment of aortic aneurysm?
It's not losartan is not superior to beta blocker. It's equivalent to the beta blocker, but what's interesting about losartan is the mechanism. So we know that the transforming growth factor beta signaling, excessive signaling, is responsible for the production of the cystic medial necrosis. So this is antagonizing this process. So at least in animals, it's proven efficacy. There is nothing to mandate not using it in human beings. So it's being used, and the results is comparable to beta blockers. But the mainstay of treatment, of course, is beta blockers, because decreasing the heart rate, decreasing the blood pressure, decreasing the rate of rise of left ventricular pressure, or DPDT, are three important pivotal lines in the treatment of this condition. You combine it with losartan, but you don't start with the losartan because of its vasodilating effect produces the opposite. If you vasodilate, you increase the three factors which we don't like for them to be increased. So you have to beta block the patient sufficiently before instituting vasodilator therapy.
اوكي، طب احنا ممكن نستخدم any other ARBs other than losartan؟
هو الترايل كلها على اللوسرتان، لكن ما هواش جروب افكت. يعني دي ستادي مر عليها بتاع 4-5 سنين لغايه دلوقتي. There is no comparable drug recommendation زي ما اتشاف في الجايد لاينز لوسرتان، وهي كلاس 2A indication. خد بالك بيتا بلوكر كلاس 1.
تمام، اوكي. سؤال بيسأل how to suspect abdominal aortic aneurysm and what is the most common presentation؟
لما نعيد بقى المحاضرة تاني. لا ده محتاج يسمع المحاضرة تاني الواحدة.
اوكي تمام. سؤال بيسأل assessment of coronaries before aortic dissection surgery.
اوكي. assessment of coronaries إذا كان العيان عنده evidence of all the myocardial infarction في الإي سي جي، أو عنده an ECG which tells you إن في definitely coronary artery disease بطريقة أو أخرى, then it's better to have the coronary arteries image. But don't waste your time. ليه؟ لأن إحنا كلنا عارفين الحكاية دي. بنشتغل على aortic root في type 1 dissection أو type A dissection أو proximal dissection. الديامتر بتاعه 7 سنتيمتر مثلا. 7 سنتيمتر دي بنقعد نشكل القسطرة بحيث إنها توصل للكورونري ونضيع وقت ونفضل نتحرك في الاورتيك روت we might extend the dissection. So if you have the ideal catheter, if you have the immediate help and if you have images كويسه then العيان ده هو ممكن تعمل له coronary artery. If you have time لأنك control the blood pressure وكل حاجة you can make a CT angio للعيان. CT angio takes a few minutes. لكن العيانين دول عادة ما هم صالحين للسي تي انجيو لأنهم تاكيكارديك وهايبوتنسيف وحاجات زي كده هو بيخلي السي تي انجيو يطلع بلير. So what we do unless we have a strong evidence إن في myocardial infarction وأشور إن أنا محتاج إن أنا أعرف ايه هو السبب بتاع الكورونري اوكلوجن والسايد بتاعه don't waste your time in doing that. If you waste your time and take a long time عشان تدور على الكورونري stop and let the surgeon find himself for himself الكورونري. بيدخل بروب بيتاكد ان الماوث بتاع الليفت مين والرايت كورونري ارتري is intact and then بيحسس على الكورونريز من بره ويتاكد ان مفيش اثيروسكليروتيك بلاك موجوده فيها. That's the way it goes. لان الوقت مهم جدا زي ما انتم شايفين مورتاليتي ريت وان كانت بتبتدي ب 0.22 الا انها لو طولت المده ب 0.22 بتبقى 0.77 ولذلك هي محطوطه في السلايدز دي 1 to 2% per hour. فكل وقت بيضيع وقت بيؤدي الى هاير مورتاليتي ريت. So we disregard الكوروناريز. لكن لو في ايفيدنس ان في definitely coronary هو ده اللي بنعمله. لو انت عندك اساطر جاهزه الاورتيك روت ما هياش واسعه جامد والعيان ما هوش candidate for CT we do the coronary arteriogram but we don't try hard. احنا احيانا كنا بنقعد ساعه او ساعتين عشان نعرف نخش الكورونري dilated aorta و6 فرنش كاثيتر نمره 3 امبلادز او جاتكن وما بتوصلش. في كاثيترز التيرمينال تيب بتاعها طويل هو ده اللي بيستخدم في الحالات دي. لكن as a routine it's a class 3 recommendation. we don't do ده عيان هيروح جراحه في المنطق يقول نعمل له كورونايز لا مش في الحاله دي.
اوكي سؤال بيسأل does treatment of polymyalgia rheumatica decrease the risk of developing temporal arthritis؟
لا that's the risk of polymyalgia rheumatica. Polymyalgia rheumatica is associated with temporal arthritis أو giant cell arthritis في 15%. Treatment by steroids, the small dose of steroids اللي هي 15 مللي جرام and decrease the dose over 1.5 to 2 years, 1.5 to 3 years doesn't decrease the occurrence of the giant cell arthritis. But every polymyalgia rheumatica, you should tell the patient several times. If you get headache, not necessarily for temporal regions, anywhere. If you have difficulty or pain during combing the hair, if you get jaw claudication, this is pathognomonic, jaw claudication, or you get anything in your eyes, blurring of vision, double vision, misty vision, then you have immediately قبل ما تكلمني في التليفون تزود الدوز من 15 إلى 60 وبعدين تكلمني في التليفون. So it doesn't decrease the incidence. The incidence is 15% of patients with polymyalgia rheumatica and you give them temporal arthritis, but the important point is that the patient shouldn't waste time, otherwise permanent blindness will occur. هل احنا بناخد temporal artery biopsy؟ دي ما اتشالتش، لكن if you have a skilled ultrasound man, then this ultrasound will be able to tell you if there is thrombosis and inflammation of the superficial temporal artery on either side or on both sides. So حكاية البيوبسي is going to be outdated. It's not outdated now. It's still in the guidelines. You have to get a biopsy to prove it. But the biopsy will not become negative except after 15 days. So if you start the steroids, it's not going to affect the biopsy.
سؤال بيسأل عن celiprolol for Ehlers-Danlos. Is it better than other beta blockers؟
ما فيش evidence في حاجة زي كده. هو beta blockers is beta blockers and I have no idea إذا كان كده. ما عنديش guidelines definitely ما فيهاش حاجة زي كده. لكن ممكن يكون بروموشن كوميرشال لحاجة معينة ما عنديش فكرة عنها.
اوكي تمام، هو مفيش أسئلة تاني حتى الآن.
اوكي خلاص كده، تصبحوا على خير. شكرا جزيلا. المره الجايه peripheral vascular disease.
شكرا دكتور محمد، ربنا
شكرا
يكرمك.
لست الكل.
تصبحوا على خير.
وانتم